Welcome everyone to the NCEPOD webinar. This is to mark the release of our most recent report, Learning Together, and this was a review of the quality of care provided to adults with a learning disability when they're admitted to hospital acutely unwell. So today you're going to hear from, first of all, Wendy Preston from the Royal College of Nursing, who's going to let us know why this study was important. You'll then hear from two of the report authors, Alison Tavaré and David McWilliams, who are going to tell you what we did and what we found. And then finally, we have a video featuring Gavin Howcroft, who's an expert by experience advisor, and Hilary Gardener, who's a strategic liaison learning disability nurse from Hertfordshire. So thank you again for joining. My name's Neil Smith, and I'm the Deputy Chief Exec of NCEPOD, and I'm going to hand over to Wendy Preston.
Thank you very much for the invitation to join you at this lunchtime webinar, and thank you for the invitation from the Royal College of Nursing to be able to speak. We are the professional body for nursing and the largest trade union. I'm Wendy Preston, Head of Nursing Workforce and Practice at the RCN, but I'm really here representing Jonathan Beebe, who is our professional lead for learning disability nursing, and he couldn't be here today, so he wants to send his apologies. He's had to have some leave, but he is really was one of the instigators of this report, and we want to express our thanks to NCEPOD for listening to the concerns of learning disability nurses on behalf of their patients to initiate this review. We've got a fantastic learning disability nursing forum at the Royal College of Nursing, and they've been telling us that this review is needed. I personally have some lived experience, both as a mother, but also as an advanced nurse practitioner and working across primary and secondary care. And I work as an advanced nurse practitioner currently in primary care out of hours service. So I see some of the complexities myself and the barriers that really should not be there. So we know at the moment, especially over the next few weeks, it's going to be a very busy time for learning disability nursing, and our patients and their families, and I say that as someone with lived experience, I'm really dreading hearing some of the expected reports that are coming out as to some of the poor experiences and the poor working conditions that are happening in some of the services across the UK. There's a learning disability review due to be launched next week, and I know that's going to be difficult reading as well. So it's really positive that today, whilst we might be hearing about some difficult circumstances, that we are able to work in partnership with NCEPOD to look at what can be done to make things different, and I'm excited to look at what are the recommendations from this review, and how organisations and the governments can make that happen, and then how organisations like ourselves, the Royal College of Nursing, how can we lobby and how we can influence some of that to happen. So thank you very much, and I look forward to the webinar today.
Thank you. So what we actually did, so first of all, what was the method? We looked at patients aged 18 and over with a known learning disability who were admitted to hospital as an emergency over a 6-month period. And the data source was quite considerable. Many clinician questionnaires, a lot of case notes reviewed, and thanks to everybody involved in doing that, including the backroom staff for NCEPOD, because everything had to be redacted. So it was anonymous, the notes were anonymous. We had primary care questionnaires and organisational questionnaires, and significant numbers of online responses from health and social care professionals, and also patient and carer surveys. So we'd like to say thank you to everybody who contributed to this immense data collection, but particular thanks to the patient and carers who were involved, and also Andrew Bright, who was our expert by experience, who helped really design a lot of this study, particularly at the beginning. So what did we find? It's going to be a very brief overview today, as I'm sure you're aware, but so what we thought we'd do is just share our 5 recommendations. And the first one is to accurately record a person's learning disability in the notes and on learning disability registers and lists. And this is so that the right care can start the moment somebody arrives in hospital. And it's particularly important because we know that people with a learning disability die about 20 years younger than the average population, and that they also are much more likely to die of avoidable causes. So if we can know they've got a learning disability, how can we actually improve the care that's offered? We were aware when we started this there would be some challenges because we know it's known that 2% of the population have a learning disability and only 0.5% are coded. So we knew we weren't going to capture everybody in our work. But what really surprised us was the inaccurate coding. So as you're all aware, to say somebody has a learning disability, they've got reduced intellectual ability, reduced ability to be socially independent, and that started in childhood. Whereas a learning difficulty is a difficulty processing, it's more like dyslexia. So not affecting intellect. However, we found that the reviewers found that in 32% of patients, not only was somebody mentioned as having a learning disability, they were also it said they had a learning difficulty. And the two terms were often used interchangeably, often in the same history entry by the same clinician. And we can't help but wonder how many patients have been only coded as having a learning difficulty, so won't even have been identified in the study. So there's definitely something to raise awareness. So if we know that somebody's got a learning disability, how can it be shared across organisations? And nearly 90% of organisations said they used alerts or flags on electronic records, and 14% had a register, much more common in primary care, less common in hospitals. But despite this, the clinicians reported that only about 50% of the patients had alerts, and 60% of the health and social care professionals said it wasn't easy to identify people with a learning disability on the EPR or hospital systems. So definitely an area for improvement. And I would ask you, how do you know if somebody's got a learning disability when they arrive in your hospital? And if so, if you can find that out, are you aware of it from the moment they first arrive? So the second recommendation is to assess and implement reasonable adjustments for patients with a learning disability. Just as a bit of background, the Equality Act of 2010 recommends that reasonable adjustments should be made to ensure that all people should be able to access healthcare equally. And these can be made at an organisational level, such as disabled parking or accessible loos, but also can be personal. So somebody who's very distressed by noise could be offered headphones. But to know what reasonable adjustments might help access, we need to start asking. And only 40% of patients and carers were asked if any reasonable adjustments were needed during the admission. Were reasonable adjustments made? Again, nearly 50% of carers felt that changes weren't offered or they weren't made to meet the needs of the person they supported. And reviewers also found that reasonable adjustments were only made for about 40% of patients, and for about 20% of patients, these were made inconsistently. Just as a flag, Gav and Hilary are going to be talking much more about reasonable adjustments later, really practical advice. So how can we raise awareness of reasonable adjustments? And it was found that if there was a coded diagnosis of a learning disability in the notes, then 60% of patients were offered reasonable adjustments. But if there was an alert or flag on the EPR or there was a learning disability register, it went up to 75%. So relatively simple ways that we identify if somebody's got a learning disability and we record it and make it available, then reasonable adjustments are much more likely to be made. And that's positive for the patients, but it's also positive for us as clinicians delivering care. A patient who's much calmer and and feels involved in their care is much more likely to engage. And I'm also just going to mention that the national reasonable adjustment flag that's coming out is going to be made mandatory in England. So do look out for that if you're not aware of it. And the third recommendation is to use decision support tools to aid healthcare professionals when assessing mental capacity in patients with a learning disability. And the Mental Capacity Assessment Act starts with the assumption that everyone has the capacity to make the decision their own decisions. And just because somebody has got a learning disability, that doesn't mean they haven't got capacity. Because we found that was a common theme in the notes, that someone's got a learning disability, they can't make that decision. It's up to us to provide information so that people are able to make a decision. But we also have to understand there's different complexity, the different decision making if you're asking if somebody wants a cup of tea, or if they feel they should have an investigation or perhaps an operation. So were mental capacity assessments made, and reviewers found that they were made consistently for about 28% of the patients, inconsistently for nearly 10%, but not at all. There were no assessments of capacity in about 60% of patients. So really significant, particularly because other studies have showed that delays in assessing mental capacity has an impact, negative impacts on the care provided. And they found that the reviewers also found that 50% of patients who didn't have a formal capacity assessment should have had one. So how can we improve this? There are decision support tools, and NHS England's done some excellent work on that and some online tools. These tools decision support tools are available in 95% of hospitals. But despite that, we were very surprised when we reviewed the online health and social care questionnaire, because 60% of the people who'd answered had assessed mental capacity in their role, but of these people, only 60% reported feeling confident in assessing capacity. So that's definitely an area for investigation and improvement. How can we enable people to feel confident? And therefore, if they can be more confident in assessing capacity, improve the care that's provided to our patients. Another improvement suggested by clinicians and reviewers include involving learning disability services, and also making reasonable adjustments, so being able to deliver information in accessible forms. And actually, as part of this, I do want to kind of flag and thank Dee for a lot of the work she's done in providing an accessible version of this report, and some accessible advice, easy read advice for people going into hospital if they've got a learning disability. And carers, in addition, highlighted the value they could add when decisions have to be made. Although they can't actually make the decisions on behalf of that person, they can support clinicians working with a patient to work out what should be offered and what investigations should be undertaken. So a quick run through of the first three recommendations. I'm now going to hand over to David, who's going to provide information and background on the next two.
Thank you, Alison. So as we move on to the next slide, I think one of the key themes really coming through that supported recommendation 4 was the need to really consistently and continuously involve people with a learning disability in their care during an admission. And that really needs to start from the point of arrival right through to discharge. And what we found through the multiple sources used was that often this involvement was quite inconsistent, and particularly around decisions regarding their care. So when we look at the case reviews, for example, just under half of all cases showed no evidence of any involvement in the patient themselves in decisions about their care. And even where their involvement was present, this was often inconsistent, again, in around half of those cases. We did find that carers were slightly more consistently involved, but again, just under half of cases actually involved discussion with family or carers about some of the care decisions. And again, this was inconsistent in around a third of those cases. So this isn't something that was being deemed consistently well. And that became really important because when we started to look at the standard of care that was provided, where carer involvement was present, those cases were twice as likely to be rated as being good overall in the care that was being given. And challenges to gaining a full history, for example, was twice as likely when there wasn't somebody who'd accompanied that person into the emergency department. So having the carer's involvement was having quite significant improvements or benefits to the care that was being provided, as was involving the people themselves in decisions about their care. And also, this becomes really important. So the lack of involvement did have significant consequences. And in the cases reviewed, we found around 1 in 5 were considered to have adversely affected the care provided because the patient had a learning disability. So 1 in 5 all cases, and that was things to either a delayed diagnosis, delays with investigations, or a lack, as Alison had already mentioned, around reasonable adjustments. So that lack of involvement was having a real impact. When we talk about the role of carers, we surveyed organisations and they felt that they were providing good levels of support to carers coming into supporting people in hospital with a learning disability. But again, there was evidence that this was lacking in multiple places around the lack of carer passports, for example, access to toilets or meals, support with car parking and staying overnight. So whilst they felt there was an organisation perspective, things were in place, this wasn't always being discovered in the patient notes. And again, that lack of involvement went right through to discharge, where we found that in 41 or nearly 42% of cases, there was no involvement of either the carer or the individual themselves around discharge planning. And one of the nice things you'll see in the report is we have examples of case vignettes. And within there are some examples of where poor discharge planning has ultimately led to patients needing readmission to hospital or challenges in the community. So quite a really big problem in terms of that discharge planning and processing. As we move on to the next slide, one of the things that is also considered is the support services available as patients come into hospital, and considering the role of learning disability support services and acute learning disability support teams, for example. And what we found as part of the report was that actually these services weren't always available, and when they did, it wasn't always consistent and equitable care. Many acute learning disability services lack capacity or wider multi-professional input. And you'll see it only around less than 1 in 5 hospital learning disability services were multi-professional. Just over a third were single professional or made up of a single individual, and that was often in nursing. Around 2/3 of the acute learning disability services in hospital operated during weekday working hours only, and that specifically limited support for emergency admissions. And during the case review process, we found that only 17.9% of patients were reviewed by the learning disability service within the emergency department. And again, that figure becomes important because when we asked our case reviewers their opinion, they felt there were another 116 individuals that would have benefited from early learning disability service support at that time frame. And again, thinking about some of those consequences around delays in diagnosis, delays in investigations, or a failure or delay in the introduction of reasonable adjustments. And like with the carer involvement, one of the key themes coming through was there was a really strong message that where learning disability services were in place, care was better. And actually, it was almost twice as likely again to be rated as good. And that was through improving things like communication, the involvement of carers, the completion of capacity assessments, support and education for staff in the wards, and again around the support of discharge processes and liaising with community learning disability services. So these seem to be very important services to improve the care for people admitted to hospital with a learning disability. Obviously, what myself and Alison have done there is giving you a bit of a snapshot of some of the headlines and some of the key findings. There's a lot more data that went into these reports, and hopefully you'll all go and have a good read of the report themselves. But just to highlight on the website, there's also a number of other resources available. So alongside the reports, there are recommendation checklists, there are audit tools, so people can go and have a look at what the services are like in your own organisation, for example, guides for commissioners and many, many other things. So you can access those via the QR code that's on screen now, and I would encourage you all to go and have a look. What we're going to do now is we're going to hear from Gav Howcroft and Hilary Gardener, who's going to talk about really the importance of this report and specifically focusing as well on reasonable adjustments.
Hi, this is Hilary Gardener. I'm one of the community learning disability nurses in Hertfordshire, and in front of me you can see Gavin Howcroft. Do you want to just introduce yourself, Gavin?
Hello, my name is Gavin Howcroft. I'm an expert by experience advisor for Hertfordshire County Council in the Health Liaison team.
So we've been asked to give you a little bit of info about the impact of reasonable adjustments, because we've worked really hard over the years to gather examples from Gavin's experience of just how much of a difference the tiniest action can make to really changing someone's health experience and health outcomes. So in Hertfordshire, we use an acronym. Gavin, do you want to just talk through the acronym?
So we got an acronym called TEACH. Each letter teach is a reasonable adjustment you can make for people with learning disabilities. You've got T for time, E for environment, A for attitude, C for communication, and H for help.
So Gav, do you want to just tackle T for time? T for time. What impact has you had in your health experiences about people using time to help you overcome barriers?
So time is about making time for someone with a learning disability. This could be double appointments, longer appointments. I need longer appointments because especially if I'm in a stressful environment like a hospital, I can become very nervous very quickly, and I can straight away be like, yes, yeah, okay, yeah, I understand, when actually I don't understand at all. Also, it's about making that right time of day for somebody, because if you've got somebody who's like an autistic person who goes to daycare each week, that might make it harder for them if it falls on the same day appointment as their daycare. So, you know, time can really help people with that.
I think that's really important, that we have to acknowledge that it's not just sort of thinking, well, for goodness sake, miss your daycare, your health's more important. It's about recognising that the cognitive ability of that person might mean that they can't process that health is more important than day service, and therefore they will refuse to have the investigations, isn't it? It's that sort of element. So you have an example as well about your stress levels and time, don't you?
Yes, so when I was in hospital last year and I had to have a procedure done, they knew that if I had to wait all day for this procedure, I would just get more nervous, and in the end I might say I can't do it at all. So they set it up that I had it straight away first thing in the morning. That meant that even though I woke up and I was nervous and worried, they made sure that a nurse came and spoke to me and kept me calm, and then I was straight away, had the procedure done, and I was back in the ward. That really helped, just making that right time for me.
And without that, you potentially would have refused
that
or not been able to have that.
Yeah.
Thanks, Gav. Okay, Gav, now to E. That's E for the environment that you're seen in for medical help. Can you just run through your example for that?
Yes, I can get quite anxious in environments, especially in hospitals. A couple of years ago, I had to go to A&E due to a DVT. When I got there, I went to the receptionist and I said, hi, I'm here because I got a DVT. The first thing she said to me was, okay, can you sit over there, please, and do not shout at me. I was a bit confused because I was like, well, I didn't shout at you. I then sat down and another nurse came to me and she said the same thing, can you stop shouting at me? I then was thinking, why is everyone getting cross with me and saying I'm shouting? I'm not. Then people were giving me weird looks, and a security guard came over and said to me, Gavin, if you don't stop it, I'm going to take you out and escort you off the premises. Apparently I was doing things like rocking and going red, and I was shouting. I didn't realise I was showing this behaviour. I understand that people who don't know me and that me showing those kind of signs can be very worrying for them in case they feel I'm going to get violent, but I'm not. When I get like that, I just need reinsurance. Things like side rooms or going outside for 5 minutes can really help in that situation.
I think that's really important. It's really hard for a health professional to know when somebody is actually bordering on aggressive or when they're bordering on petrified, and trying to utilise the help of people around them or health passports or anything else is so important, isn't it, to work out how to respond to that, because we automatically go to that defensive response of, you know, quick, he's going to blow. But actually what it needed was someone to just be empathetic and say, you seem upset, you seem distressed, are you okay? What can we do to help you? Wasn't it? That's all you needed.
Yeah.
And for you to be able to go outside. So it's recognising that if someone's displaying strange behaviours, start by saying, you seem distressed, you seem upset, what can I do to help? Rather than assuming that they're about to, you know, become aggressive. Thanks, Gav. Great, thanks, Gav. Now we're on to A for attitude. And as we always say, attitude isn't about saying, oh, bless, it's about getting the same outcomes, isn't it? So tell us about your experience of attitude.
So this example wasn't actually in hospital, but it had a massive outcome for later on. Years ago, I was petrified of needles. I would just say no. I would walk out of hospital appointments, doctor's appointments, whenever it came to being told I needed to have a needle. One day, a nurse at my local GP called me in to talk about it. At first, I was very reluctant. I was saying, no, I don't want to talk about it. She then said to me, Gavin, can you just explain to me, in your own words, what it is you don't like about it? And I said, well, why would I like it? You stabbed me with a needle, it hurts, it's not nice, why would I want that done? And she said, that's great, Gavin. If you ever wanted to look up something, you could type in Google, you could go on your phone, or you could look in a book. We unfortunately can't go on our laptops and type in Google or look in a book if we wanted to find out what was going on inside of you. But a blood test can do that. She then said the words which still ring in my ear today, that a needle could save my life. No one had ever told me that before.
When you'd been to doctor's appointments and nurse appointments before and you'd walked out, they'd generally said, you don't worry, Gav, you don't need it, hadn't you?
Yeah.
And you had read that as meaning, I don't need a blood test.
Yeah.
They hadn't explained the impact.
No.
It's mental capacity, isn't it? They hadn't explained the impact of not having the blood test and what could happen.
Yeah.
Yeah.
Last year when I was in hospital, I needed lots of blood tests, and I think if it wasn't for that understanding of it, I don't think I would have really found last year hard, due to me refusing needles.
Having known you from before your needle phobia, before it was resolved, and seeing you in hospital last year, I can safely say I think you potentially could have lost your life to sepsis last year as a direct result of you refusing things, because it was a needle saves my life that kept you going, wasn't it?
Yeah.
Now it's C for communication.
So communication is actually one of my biggest barriers to my learning disability. That's not because I can't communicate with you. I can talk to you about almost anything. But when it comes to health, that's where my communication cannot always go right. A couple of years ago, when I was at the hospital about the DVT, the nurse came up to me and said that I needed to go home and self-inject myself with needles. Straight away I said, I can't do that, I'm not a doctor. She then said, oh no, you can do it, it's very easy. I said in the end, I can't do it at all, I'm really sorry, I can't do that. And she said, well, if you can't do it, you have to stay in hospital. Straight away that scared me, and I went, oh no, okay, yep, I can do it, yep. And she went through it all, and the whole time she was going through it, I was going, yep, okay, yep, pinch the skin, yep, okay, twice a day, yep, can I go now? Okay, yep, no, that's fine, yep, I know it's important I do it, okay, can I go now? When I went home, I had a box of needles, which I really didn't have any idea what to do with. When I got back in, my wife said to me, the first thing she said to me was, Gavin, what are these needles for? I said, I don't know, but I'm not going to do it. I said, I'm having a scan, I'm seeing a doctor in a few days, and I don't need to do it. Well, my wife knew that I wouldn't come home with a box of needles for nothing, so she convinced me to go and see the GP the next day. When I went the next day to the GP explained to me that these were emergency blood thinners to stop the DVT from making me even more ill or even possibly killing me, and that it was important I did this and that they would help me. I'm sure that nurse explained all that to me when I was at the hospital, but because I went into what I call my emergency mode, which is yes, I just wanted to get out of there, so I just said everything she wanted to hear to get out.
Yeah, I mean, communication, that's a huge element of people misunderstanding that you understand more. And then also we often have health professionals saying that, especially somebody who's more learning disabled and non-verbal, they often will say that they can't communicate with the person because of that, and they come in and they instantly talk to the carer, and they know the rules, talk to the person, but don't want to make a fool of themselves by talking to someone who's not going to be able to talk back. But the most important thing is 90% of communication is non-verbal. That nurse should have picked up your non-verbal cues. But also, you are oozing communication as a health professional. You need to ooze that communication to the person. That means when they come in, even if they're non-verbal, just saying, hello, we're going to sort you out. Oh, gosh, that sounds like you're having a tough time. As you're talking to other carers, that will make the difference between them when you want to do something investigative to them, between them feeling trust and safety in your presence or feeling apprehension. If you ooze apprehension, you are going to give apprehension, and you are going to yourself, through your non-verbal communication, be a barrier. And that's unfortunately twofold, isn't it, then, in communication?
Yeah.
Thanks, Gavin. Now H for help. Gavin, what help do you have?
So when I was in hospital last year, a nurse knocked on my door and came in and said, "Hi there, I'm here to install a PICC line." Straight away I got very nervous, and she saw this and she said, "Would you like me to explain it a bit more to you?" And I said, "Yes, please." She then explained it more, and then she said to me, "So Gavin, would you like to feed back to me what you understand?" And I said, "I understand, but what I'm nervous about now is I don't like the fact that there's this tube in me and they're stuck on by hooks on my skin." I said, "That makes me feel really nervous." And she said, "I tell you what, Gavin, I'll go and speak to, I did someone up here not long ago. I'll go and get them and get them to talk to you." So then this chap came in, he reassured me that everything was okay once it was in, which really then reassured me to have it done.
So he was another patient, was he?
He was, yes.
Right, wow.
Yes.
Yeah.
And when I was having the procedure done, there was two PICC nurses, and one of them was doing the installing and the other one was talking to me about my job and distracting me from the procedure. Halfway through, my wife came in and got a bit scared and went out. That straight away got me more worked up, and the nurse said to the other nurse, "Can you carry on talking to Gavin and distracting him, please? I'll go and get his wife and make sure she's okay." She went out. 10 minutes later, my wife came in, who had completely understood exactly how good this was to me and encouraged me more to have it done. So help is about that. It's about encouragement, help, getting those other people to help make that right.
Getting another patient was really thinking outside the box, wasn't it? Because that made a huge difference of trust. Yeah. And help comes in all shapes and sizes. Often people who've got a partner who's got a learning disability, they assume that, I don't need two people in here. You and Naomi have a really positive approach, don't you, of what you can do and what she can do, and you work as a real double act.
Yes.
And people don't often respect that. No. Naomi's got really good insight and support mechanisms for you.
No, she's got much more better now though. She really does speak up. The other day I went to an appointment and they was like, "Oh, no, I haven't got room for you and another person." And my wife said, "Well, I need to be there for Gavin because he's nervous and I need to help reinsure him."
That's excellent, because before she would just run out the room if they told her to leave, wouldn't they?
Yeah.
So you guys have really got a good team going. So help is about, if today I'm not achieving what I would achieve had the person not got the barriers due to their learning disability, what help can I get? Whether that's community learning disability nursing, whether that's another patient, whether it's their partner, whether it's their carer, family. It's about finding the right people who can help overcome those barriers where you can't. So that's us, and that's Teach. Thank you very much, Gavin, for your help today. And
no worries.
Thank you all for listening.